My name is Cray Bolger, part of the ultrasound faculty at Ohio State. Today we're going to discuss the sonographic evaluation of the shoulder. As with any exam, why are we doing it, how are we going to get the images, and what are we going to do with them? For the shoulder, the primary indication is for procedural guidance, whether it is arthrocentesis or shoulder injection, typically for pain control with steroids, or a block for a procedure. Another application is for shoulder dislocation and reduction. Some pathology we may encounter is AC joint separation, rotator cuff injury, effusion, or fracture. One caveat is that ultrasound is not very sensitive for most of the shoulder pathology. To begin, we have our patient typically sitting upright with their elbow flexed at 90 degrees and their palm up sitting on their lap. We place the probe, typically a linear probe, in the anterior shoulder with the leading edge facing lateral. We will do this just over the biceps tendon. The curvilinear probe will be used for evaluation of the posterior shoulder later. To begin, we will have the patient rotate their arm, palm up, internally and externally. The biceps tendon will appear round and slightly hyperechoic, sitting in the bicipital groove of the humerus, and medial to this will be the subscapularis, which will come into view as the arm is rotated externally. This will appear as a bird's beak. The humerus will be in the far field with a hyperechoic periosteum and shadowing behind it. Next, we will have the patient rotate their shoulder by placing their hand behind their back as if to put it in their back pocket. This will bring the supraspinatus tendon into view from the lateral portion, approaching the biceps tendon. The final tendon we will typically evaluate of the rotator cuff is the infraspinatus muscle and tendon. This is done in the posterior aspect of the shoulder with the leading edge facing laterally. As you can see, the infraspinatus tendon comes from the medial aspect over top of the scapula and wraps over top of the humeral head. One of the more common pathologies we can diagnose on ultrasound is shoulder dislocation. You can see on the left side that the humeral head interfaces nicely with the glenoid of the scapula seen here. This is a normal joint interface. In this image, the leading edge is facing lateral on the posterior aspect of the patient's shoulder. In a shoulder subluxation, the scapula will again appear triangular. However, you'll notice here that the glenoid fossa is empty as the humeral head has dislocated inferior and anterior. This is placed in the same position, leading edge facing lateral in the posterior aspect of the right shoulder. What we can do is evaluate for possible shoulder subluxation prior to procedure and then sedate or medicate the patient, reduce the shoulder, and confirm a successful reduction without the patient having to go anywhere or wait for any other imaging modalities. In summary, ultrasound can be used for procedural guidance and pathology identification of the shoulder. However, it is not sensitive or specific for most of the pathology that we are looking for outside of subluxation. Rotator cuff pathology can occasionally be identified by noting anechoic fluid around the supraspinatus, infraspinatus, or subscapularis tendon. And as discussed previously with any tendinopathies, we look for rippling of the tendon as signs of partial avulsion. Ultrasound-guided procedures such as arthrocentesis or shoulder injections have higher success rates and decreased complications.